Welcome to the online module entitled Conservative Management of Pelvic Floor Muscle Dysfunction. My name's Lori Mize, and I'm one of the instructors for the Academy of Pelvic Health. If you're viewing this module, you are signed up for one of our pelvic courses or one of our OB courses, and we're so glad that you're joining us and joining in to the pelvic health profession. Welcome. For the rest of this online module, we will be speaking about terminology. And so this is a really important endeavor by the International Continence Society or the International Urogynecological Association. These are two international groups that have banded together to generate a terminology report so that all pelvic health professionals across the globe can use the same terminology and understand what we're saying. The best way to follow along with this module would be for you to download your pre-reading. Download this article. You have it available, and the primary author is Kari Bow. This is from 2017. And if you want to just follow along with that article, or just take notes on a separate sheet of paper, things that you think of, or type whatever works best for you for your learning. There's no specific module that goes along with this in our pelvic course manual. So take notes and just listen however it works best for you. For the duration of this module, we're going to be talking about these terms that are critical to understand in your clinical practice. Let's move forward. So like I mentioned, this is a joint report on terminology by the ICS and IUGA task forces. And so their emphasis in this terminology report is for conservative management of pelvic floor dysfunction, or PFD as it's abbreviated, which is great because this is non-surgical or non-pharmacological approaches, and that's what we specialize in as physical therapists. We are the specialists of the neuromusculoskeletal system, specifically in the conservative management of those systems. So that really puts us at a very important seat at the pelvic health table. And as you can see, Kari Bow, the primary author here on this terminology report, is a very well-known international researcher in physical therapy and in the pelvic floor. And so buckle up, join on in. We're glad to have you on board in this pelvic health journey. Let's learn more about terminology. So there's also a report that we're not going to spend a lot of time talking about in this particular module because you will learn more about this when you take the bowel coursework in the pelvic health series with the Academy of Pelvic Health. But there is an anorectal terminology update as well. And I've put this up here for you guys to see that reference so that you can look that up and you can download that as well. So, conservative management of pelvic floor muscle dysfunction includes an assessment, and that's where it's really important that we get an accurate history. I love to use significant, sometimes very lengthy, health history intake forms that the patient can fill out about their symptoms, about their history, to help streamline that process in the evaluation. But a good, thorough history is absolutely critical. And then we're going to do components of the physical examination depending on the patient's history and presentation. And then various investigations or tests and measures that we perform as a physical therapist. Then in our evaluation process, we formulate a diagnosis. We incorporate preventative techniques and measures to prevent further dysfunction further down the road. And then we incorporate our interventions for treatment of pelvic floor dysfunction. We're going to break those down a little bit more. So when it comes to looking at pelvic floor dysfunction, the article by ICS and IUGA talks about symptoms, signs, and also investigations. So we're going to break down various categories in those symptoms and signs and investigations and talk about those specifically. So symptoms are defined by the report as any morbid phenomenon or departure from the normal in structure, function, or sensation experienced by the woman and indicative of disease or a health problem. So basically, in a nutshell, symptoms are what the patient is experiencing and what the patient is telling you about what they're experiencing. And then the report defines signs as any abnormality indicative of disease or a health problem, discoverable on examination of the patient, an objective indication of a disease or health problem. So basically, signs are the tests and measures that we perform and the outcomes of those tests and measures. What do we see in the clinic? What do we observe? What do we feel whenever we perform these specific tests and measures? And then investigations are defined as all methods and devices used for assessments. And we'll talk about some of the various forms of investigation a little more in just a minute. So let's talk now about the category of symptoms and break that down even more specifically. So symptoms in the article, as you'll see, are broken down into 9 categories. These categories include urinary incontinence symptoms, bladder storage symptoms, sensory symptoms, voiding and post-micturition symptoms, pelvic organ prolapse symptoms, symptoms of sexual dysfunction, symptoms of anorectal dysfunction, which is covered more in that previous article for the slide that I talked about that, lower urinary tract infection, or also known as UTI, or lower urinary tract pain and other pelvic pain. So, urinary incontinence symptoms. It's important that you understand as a clinician that urinary incontinence is defined as any involuntary loss of urine. So a lot of people will say, well, I don't have urinary incontinence. I just leak a little bit whenever I run, or I just leak a little bit whenever I sneeze, or only leak occasionally. That is urinary incontinence. Any leakage that's not intended is urinary incontinence by definition. Now, stress urinary incontinence, that is when there is a loss of urine with effort or physical exertion. For example, achoo! When you cough or sneeze, that increases the intra-abdominal pressure that you feel in your abdominal pelvic cavity. And any increase in that intra-abdominal pressure or physical exertion can cause pressure to push down onto the organs. And so, as you can see here in the muscles that surround the urethra in this image, if those muscles aren't nice and strong, then they're not going to be able to hold urine in and keep you from leaking. So that's stress incontinence, loss of urine with coughing, sneezing, running, jumping, anything that means an increase in intra-abdominal pressure or an increase in exertion. And then urge urinary incontinence. This is a different type of incontinence. And this is loss of urine that occurs along with the urge to go to the bathroom. So typically, patients who have urge urinary incontinence are the ones that are leaking on the way to the bathroom. They get the sensation that they need to go to the bathroom and then they lose their bladder contents. Or they're trying to hold it, but they're leaking on the way. These are the patients that the commercials that gotta go right now, that's these patients. Okay, oftentimes they're rushing to the bathroom as quickly as they can in order to try to make it before they leak. Postural urinary incontinence occurs whenever you lose urine with changing positions. Okay, there could be lots of different reasons why this occurs. It could be that there is a prolapse of the organs into the vagina, and so moving kind of unkinks the urethra and releases something that was previously kinked and blocked by a prolapse. Who knows? It takes a little bit more investigation. Maybe these patients are breath holding so much that they're increasing intra-abdominal pressure that every time they stand up out of a chair, they hold their breath and they leak. So sometimes it's something as simple as that. And that's actually quite easy to intervene as a physical therapist if that's the cause of the postural urinary incontinence. Nocturnal enuresis is loss of urine while sleeping. So this is bedwetting. We see a lot of this diagnosis with children, and then sometimes this can happen with adults as well. And then finally, mixed urinary incontinence. This is actually a combination of stress and urinary incontinence. You have patients who have leakage both with effort or increases in intra-abdominal pressure, but also with urge or on the way to the bathroom. That's mixed incontinence. And you're really going to see a lot of patients out in the clinic that have both urge and stress incontinence. So they have mixed incontinence. They may not come in with that on a prescription or as a diagnosis, but you will identify that very, very quickly in your history and your intake. And then continuous urinary incontinence is just continuous leakage that occurs. Oftentimes the patients often have insensible urinary incontinence, and so that's when they can't really feel when they leak or how it occurred. That can occur alongside continuous leakage, or it may not. Oftentimes the continuous incontinence, this really needs more of a medical evaluation because we need to figure out what's causing that continuous leakage. Is there a fistula or an opening or a tear in between two openings, let's say between the urethra and the vagina? Or is this because they're having retention of urine in their bladder, meaning that they're not emptying their bladder appropriately? And then what starts to happen is the bladder just starts to have a continuous leakage. So this requires more medical investigation in order to determine the cause of the continuous leakage. And then there's coital incontinence, which is leakage while the patient is having intercourse. Now it's really important to understand that sometimes women are confused. They may have increased levels of vaginal lubricant, or what we would consider to be female ejaculation, which can be a little bit controversial whenever you're looking at female ejaculation in the literature. But there's glands that are inside the urethra that can produce this lubrication and this, what some would call female ejaculate. And so some people feel like that leakage is urine leakage. So one really good way to tell if someone is actually leaking urine during sex, which is the definition of coital incontinence, it's actual urine, is to do the AZO standard test, or it's over-the-counter Pyridium. You can get AZO, A-Z-O, in your local pharmacy. And this is typically taken as a bladder analgesic. For people who have urinary tract infections or bladder pain, they'll take this medication and it turns your urine highlighter orange. And so if that is what they're seeing when they're leaking, then you know that it's urine. If they don't have that, then you know it's probably something else, that increased vaginal lubricant or that urethral lubrication that occurs specifically during orgasm. So, bladder storage symptoms. This includes the diagnosis of urinary frequency. So, increased daytime urinary frequency, or otherwise known as urinary frequency, is typically whenever you go to the bathroom more than 8 times in a 24-hour period. So, if you're going to the bathroom more frequently than that, it's considered urinary frequency. Our typical habit of going to the bathroom should be a 2 to 5 hour voiding interval. And sometimes, depending on what you're drinking, so it does depend on the context and the situation, you may urinate less time than that. But as a whole, we want to shoot for 2 to 5 hours and 8 times in a 24-hour period. That includes at night. Now, nocturia is a separate diagnostic category or symptom that is defined as voiding at night that is preceded and followed by sleep. And it has to be considered bothersome for the patient. It's typically considered bothersome at more than 2 times per night. But you may have your occasional patient who would consider getting up once at night to be incredibly bothersome. So usually 2 times a night or more is considered nocturia. And then urgency is that strong sensation that you need to go to the bathroom. This isn't to be confused with just a normal sensation to go. Urgency is that very strong, powerful, almost panic. I've got to get there. I've got to get there fast. What if I leak? What am I going to do? And they just kind of have this panic. That's urgency. They're often rushing to get to the bathroom. Now, overactive bladder symptoms actually include all of these things: increased daytime urinary frequency, or nocturia, urgency, and oftentimes overactive bladder will have urinary incontinence as well. So overactive bladder is really, it's kind of like using the patellofemoral syndrome diagnosis. Overactive bladder is like, we've got all these symptoms, we've got all these things. Let me just give this broad diagnosis, and then you've got to figure out what's going on to really cause these things.